Hi, my name's Melissa Kerrigan and I'm a psychology student. Today I'm going to be talking about the symptoms, etiology, assessment and treatment of selective mutism. Selective mutism is a relatively rare disorder that usually begins before the age of 5. However, children tend to either outgrow it or receive treatment for it, so the long-term course of the disorder has not been well studied. Somebody you might recognise with selective mutism may be the character Rajesh Koothrappali from the popular sitcom The Big Bang Theory. So let's begin. We can find the symptoms for selective mutism in the DSM-5. The first diagnostic criteria for selective mutism is a consistent failure to speak in specific social situations in which there is an expectation for speaking despite speaking in other situations. The second diagnostic criteria is that the disturbance interferes with educational or occupational achievement or with social communication. The third diagnostic criteria is that the duration of the disturbance must last at least 1 month. The fourth diagnostic criteria is the failure to speak is not attributable to a lack of knowledge or of comfort with the spoken language required in the social situation. The fifth diagnostic criteria is that the disturbance is not better explained by a communication disorder and does not occur exclusively during the course of autism spectrum disorder, schizophrenia, or another psychotic disorder. Unfortunately, there's no clear cause or etiology of selective mutism, but there are risk factors such as having personality traits such as neuroticism or having behavioural inhibition. So that's a tendency to have an anxious or negative emotional state and to experience distress and therefore withdraw from unfamiliar people, places and situations. Some other risk factors include if the person has a slight difficulty with understanding the language, but they still test within the normal range. If their parents have a history of shyness, social isolation or social anxiety. Another risk factor is that the parents may have modelled social inhibition. They may have been overprotective, controlling, and there's also shared genetic factors between social anxiety disorder and selective mutism. While we're uncertain of the exact cause of selective mutism, there are some theories. One learning and behavioural psychological theory is that selective mutism is a response the child has learned through negative reinforcement. The child remaining silent has in some way been functional and adaptive for the child. For example, the child may generally be quite shy and has learnt that if they don't talk to people outside their home, they won't be forced into uncomfortable social situations, which may cause them anxiety. To assess for selective mutism, it is essential to use multiple tools, such as an unstructured interview, observations of the client's behaviour, and psychometric tools such as the Selective Mutism Questionnaire. The first step in assessing an individual is to conduct an unstructured interview. This is to evaluate the client's present concerns, functioning, and to look for signs of clinical issues. However, due to the nature of selective mutism, the client may have difficulty communicating with the assessor. Therefore, it is likely you may have to talk to the client's parents or other adults closest to them. To begin an unstructured interview, you want to start asking general questions about the client's medical history. For example, is there any medical reason why they're not speaking? Their psychological history, their developmental history. Did they have speech issues growing up? Could they not be talking due to developmental delays rather than selective mutism? Also the family medical and psychological history. Does the family have any diagnosed anxiety disorders or speech difficulties? You also want to look into the client's daily routine, eating, sleeping, socializing, things affecting their stress levels, their cultural history. So, for example, is not speaking in certain social situations normal for this person's culture? You also want to find out their psychosocial supports, so their family, their friends, their schools, teachers, whoever can help them out, and their school, academic and work history. So how has not being able to speak affected their school or occupation? Is it a consistent issue that's lasted over time, or is it a new issue? You also want to check their legal history. So it's possible that someone may want a diagnosis of selective mutism to get out of some sort of legal repercussions. You know, for example, oh, I didn't talk to the police officer because I have selective mutism. You know, you have to find out whether that was actually the case. It's also essential to take note of the client's behaviour during assessment. For example, what sort of clothes have they decided to wear? What's their grooming and hygiene like? Are they slouched over? Are they sitting up straight? What's their gait, motor movements, their speech like, facial expressions, eye contact? Are they even looking at you? Their level of attention, alertness and arousal, just talking to you, and if they have any need for repetition. So once you've gathered the information from the unstructured interview and the observations of their behaviour, you will likely have a good idea as to whether or not the client is presenting with symptoms of selective mutism. If they are, it's a good idea to then get them to complete a psychometric tool that measures the severity of those symptoms. In the case of a child, you'll then proceed to have their parents or close adult complete the Selective Mutism questionnaire. The Selective Mutism questionnaire is one of the most widely used standardized questionnaires for selective mutism. It is a 17-item parent report measure assessing the frequency of a child's speech in multiple situations. Unfortunately, the Selective Mutism questionnaire was only created for children, and there's no standardized adult selective mutism questionnaire. However, there is often comorbidity between selective mutism and other anxiety disorders, particularly social anxiety. It would be wise to assess for additional anxiety disorders by having the client complete the Beck's Anxiety Inventory. Once you have completed the assessment with the client and possibly the client's parents, you may wish to continue your evaluation by speaking to the client's doctor, teachers, or other close adults. Alright, so the client has been assessed and found to have selective mutism. The next stage is treatment. Unfortunately, there's been limited development and evaluation of treatment for selective mutism, as it is a relatively rare disorder. In general, though, behavioural treatments are the most recommended. Some common behavioural interventions include hierarchical exposure, shaping, and stimulus fading. Hierarchical exposure is where the client is exposed to feared situations from the least to the most fearful. So, for example, a least feared situation for a child with selective mutism may be where they're in a room talking with their parents. A step up from that would be where the child is in a room talking to their parents and their teacher is in the hallway and they know this. The next step may be that the teacher's at the doorway while the child is talking to their parents. And then that can keep going until the child is talking to the teacher and the parent has left the room, and that would be considered maybe the most fearful sort of situation. Cognitive behavioural interventions are often successfully used for treating anxiety disorders, but there's no clear evidence of its effectiveness for selective mutism. This may be due to a lack of research in the area, or that cognitive intervention may be too taxing for young children, who are the ones that usually present with the disorder. However, there has been some research that shows that cognitive restructuring can be useful. Cognitive restructuring is where the therapist works with the client to identify and challenge maladaptive thoughts and reasoning the client may have for not speaking. The client and the therapist then work together to replace fearful or worrying thoughts with coping self-statements. Pharmacological interventions can also be used in the treatment of selective mutism. They work on minimising the anxiety symptoms that are related to selective mutism. The most commonly used are selective serotonin reuptake inhibitors, such as fluoxetine. However, due to the risk of side effects and the limited evidence for pharmacological treatments, they're usually left as a last resort for selective mutism that is resistant to behavioural and cognitive treatments. The outcome of these treatments can be measured by using the assessment tools I mentioned earlier to reassess the client after treatment. For example, if their selective mutism questionnaire score has risen, it shows the child has been talking more to people outside their home. Thank you for watching, and I hope you've enjoyed learning about selective mutism.